You guys will get a copy, you can do what you want with it.
I'm photographing.
I'm sending it.
Yeah, that's fine. should do a video on.
This is what I do.
Okay, right.
Back up like 2 feet and you're good.
Okay. All right. So just start recording, we'll do it miscellaneously. Okay, folks, by popular demand and request, here it is. For me, this is a really big jump in neurodynamics, and it's a mechanism that we're pretty much validated in the lumbar spine, and we're extrapolating this to the cervical spine, or the neck, on the basis that there's a couple of studies that show correlated responses as these nerve roots behave. Now, so here we have a very complex scientific model, as was made in the 1980s when I researched this. Now, this is spinal cord, of course. This is a symptomatic nerve root, and this is the contralateral nerve root. Now, we know from the studies done with Marinko Raide, University of Eastern Finland, Professor Elavia Rapson and our team up there, we know that when you do a neurodynamic test on one side, it brings the cord down. Okay? Now, in the lumbar spine, the nerve roots are like this. So they're in a very good position to change tension in the nerve roots on the other side. However, in the C-spine, it's kind of like this. Now, with that mechanism of reduction of tension on that other side of the nerve root, we can use this to create progressions. Okay, so what we're going to do is use the spinal cord movement produced by neurodynamic tests to change tension in the nerve root. That's right, just a video bomb. That's all. Mrs. Scapula has done a video bomb.
You're famous now.
Don't worry, I'll give you a hug later. Okay, so what we can do, if we think of this as the symptomatic nerve root, we can position this nerve root in tension with the ipsilateral limb, or out of tension with the ipsilateral limb, or out of tension with the contralateral limb, and in tension with the contralateral limb. So using those combinations, we'll do 5 progressions. Okay, so we have using the ipsilateral limb, position out of tension, contralateral limb, position out of tension. So we have position out with the ipsilateral, position out with the contralateral. That's the first thing, and as a patient you would do this and just hold it there for maybe 15 seconds, hopefully reducing the arm pain. Okay, next one, position out, move out, becomes dynamic. So every time we move the spinal cord, we decrease tension in the nerve root. That's number 2. So it's position out, move out. Number 3, we'll start to treat the mechanical aspects. Before this, we're trying to take force off the nerve root, give it a chance for the physiology to improve with maybe compression or other influences. So then we start mobilising this nerve root directly to produce some mechanical effects of the nerve root, but we protect it first. Position out with the contralateral, move into tension with the ipsi. As they get better, we take the protection off from the other side. But before we do that, it looks like this. Position out, move in. Then, number 5, we will reduce the protection from the other side. Position in from the contralateral limb, move in with the ipsilateral limb. So, it's position out, move in. Number 4. Number 5, we will remove the protection from the other side. Position in, move in. And that gets us to, from number 4, which is this here, position out, move in, to number 5, the top of number 5, position in, move in. That is now a standard neurodynamic test. So all that stuff has been below your standard neurodynamic testing. So it gets us away from the old progressions, which was, if a nerve hurts, move the nerve. Apply force to it. If the nerve hurts too much, move it less. And finally, if it still hurts too much, don't do it. This is below all that, so that we can still move the nerve, taking force off it, which exerts some sort of protective mechanism possibly. And that's based on the validated mechanism in the lumbar spine. And we don't have a lot of clinical trials, and this is one that I've just reviewed for a journal, which showed that when those progressions are done in people with leg pain related to abnormal slump tests, it actually produced centralisation of the leg pain and other effects above a non-treatment group. But it's unpublished yet. That will come out. I hope it will come out soon. And good luck to the authors, because it was a good study to do. So thank you very much. Good luck with your neurodynamics. Thanks. Okay, then you'll have a